Hi everyone, my name is Cassandra Tootin and I'm with the Rosalind Carter Institute for Caregiving in Americus, Georgia. And I'd like to welcome you all to the Screening for Depression in Older Adults webinar. I'd like to welcome everyone who's listening right now. Before we begin, I'd like to introduce our presenter, Jocelyn Chen Wise, Program Director of the Fuqua Center for Late Life Depression in Emory University in Atlanta. In 2010, Ms. Jocelyn Wise joined Emory University's Fuqua Center, a nonprofit organization dedicated to increasing access to treatment and awareness of late life mental illness in order to eliminate stigma and discrimination experienced by older adults. As program director, she provides support for community projects, particularly with low-income seniors. As a licensed clinical social worker, she also works in the Emory University Psychiatry outpatient clinic, providing education, brief counseling, and connecting patients and families with community mental health and aging resources. Since 2010, Jocelyn has collaborated with the Emory Alzheimer's Disease Research Center in their support groups for persons experiencing early-stage memory loss and also their care partners. She received her master's in public health and master's in social work from the University of California, Los Angeles. Both her public health and social work training have focused on gerontology and working with older adults. And at this moment, I'd like to pass it over to Jocelyn Wise here, and she's going to continue for the screening for depression in older adults. Jocelyn?
Thank you, Cassandra. And thank you to the Georgia Division of Aging Services for inviting me to present today. I know that a big part of the work that's done by the Division of Aging Services and its statewide network of health and social service professionals is around finding ways to help people age as healthily as possible. And a big part of healthy aging is someone's mental wellness. It can be hard for people to talk about the problems that they might be having with their mood, or if they're finding that they're drinking too much, or maybe they're having trouble managing their medications. That's why I'm so pleased that the division is focusing on screening everyone for common mental health issues. Universal screening is the only way we can really systematically open up a conversation around these conditions, and otherwise they may go completely unnoticed while impacting someone's quality of life and their health care. So as you can see from this slide, we'll be talking about screening for depression, and I'm having trouble. Okay, here we go. So we'll be talking about screening for depression, and I realize that time is a limited resource for all of us, and there are many things that you're trying to accomplish when you sit down with a client. So luckily, the tools that we'll be talking about today are very brief, and they can yield a very important payoff. So we'll start off by going over some background on depression, and then we'll go over two easy screening tools called the Patient Health Questionnaire 2 and the Patient Health Questionnaire 9. The PHQ is one of the most well-studied, evidence-based tools for depression screening. It was originally developed in a primary care setting, but it's been used successfully in many populations and many different settings. So we'll go over the questions that make up the tool, how to administer it, how to score it, and some frequently asked questions. The goal of this training is to help you feel comfortable using the PHQ to screen for depression and to help you feel more equipped with helping your client take the first steps towards treatment. We're not trying to make you a doctor, a nurse, or a mental health expert in this training. We just want to make sure that you have this tool in your toolbox. So what is depression? Let's take a quick look at this chart, which shows the prevalence of mental health disorders in the general population. This data comes from the National Comorbidity Survey, which looked at a national sample of 10,000 people in the U.S. And you may be surprised to see that people in the general population have an almost 7% chance of experiencing major depressive disorder in any 1 year. So that's that first column there under major depressive disorder. And over a lifetime, there's an almost 17% chance of experiencing major depressive disorder. There are other mental health disorders on this chart that you can see are even more common, but this data is still showing that in general, people have about a 1 in 6 chance of experiencing major depression in their lifetime, and that's pretty high. Also, keep in mind that major depressive disorder is the most severe depressive disorder. There are many people who experience mild or moderate depression, and that still has an impact on their health and could potentially cause impairment. Now, what is depression? Back in the day, people used to think that depression was purely based on your emotions and maybe your personality. Sometimes depression was thought of as a moral failing or as something that happened to people who couldn't, quote, pull themselves up by their bootstraps. But what we know now is that there's definitely a biological basis to depression. It's a physical condition that affects the brain, and that makes sense, right? Because we now have medications that are effective for treating depression, and that's because they work on different biochemical mechanisms in our body. And we also know that there are various risk factors that may increase your chance of developing depression. One is your family history and your biology. People who have a close family member, like a parent or a sibling, with major depressive disorder have a 2 to 4 times higher risk of developing depression than people who don't have a family history. And that's because depression, like many other diseases, has some amount of heritability. It's a condition that can be inherited to some degree. Second, we know that life experiences in someone's environment definitely plays a role in whether someone develops depression. I think it's pretty intuitive that stressful or negative experiences can kind of set you up for depression or bring on a depression. And lastly, we know that someone's temperament or their disposition can be a factor in whether they develop depression or not. So more than 6.5 million people age 65 and older experience depression, and so it's very common. There are people who think it's a natural part of getting older because of the losses that tend to come later in life, but we know that depression is not actually something that we should accept as a normal part of aging. It is, it's a physical disorder of the brain, and it is treatable. You might find it interesting to know that depression is common among people with Alzheimer's, and it's actually the most common treatable risk factor for Alzheimer's. And that means that research has shown that there's a connection between depression and dementia. And there are different theories as to why depression seems to precede dementia. What we know definitely, though, is that depression gets better with treatment, and so do the cognitive symptoms that come with depression that may look like dementia. And this becomes a little clearer as we talk through the diagnostic criteria on the next page. All right, so if we're looking at the symptoms of major depression, we're going to be looking at that based on the diagnostic criteria listed in the Diagnostics and Statistical Manual, the DSM-5. And there are 2 core symptoms of depression and 7 other symptoms. So to meet criteria for major depressive disorder, a person has to have at least 5 symptoms here. And they have to, of the 5 symptoms, they have to be experiencing at least one or both of the 2 core symptoms. So we're looking at these symptoms over the course of a time period too. We're looking at them over the course of 2 weeks. We're not asking someone to think about their entire life and kind of sum it up. We're just looking at sort of current symptoms. They may have been experiencing the symptoms for longer, but really we're looking to see if they've been happening recently. So let's go over the symptoms. The 2 core symptoms are 1, a depressed mood or sadness, and 2, a lack of interest. Now, depressed mood probably is pretty intuitive. It's sort of what we think of naturally when we think of depression, feeling kind of down or blue or sad. But this lack of interest core symptom is something that people miss sometimes. Lack of interest means that maybe you had a lot of hobbies or you used to be very involved in your church or your family activities, but now you're just kind of feeling like you can't be bothered. It seems like so much effort, not really interested in doing the things that you used to be interested in. If you're finding that these interests are sort of going away, then that is actually a core symptom of major depression. You don't actually have to say that you feel sad in order to meet criteria for major depression, but you do have to have this lack of interest. Other symptoms that are associated with major depression are a change in weight or appetite, and this could be up or down. So you may be having you might be finding that your appetite is really high and you're eating a lot more. You know, you kind of think of stress eating, people sort of eating when they're feeling anxious or down. Or you might find that your appetite is kind of completely gone. And changes in your weight that might come with that could also be up or down. So when you're interviewing somebody about their changes in appetite or weight, make sure you kind of probe a little bit. It's not just about eating too much or eating too little. Problems with sleep are very common with depression. And again, this could be sleeping too much or sleeping too little. It could be having trouble falling asleep. It could be trouble staying asleep. So probe a little bit with the person that you're talking to about what's going on with their sleep. Are they just, napping for hours a day? Are they having really broken sleep throughout the night? See what the issue is going on. This third criteria is agitation or retardation. That has to do with how somebody's moving. So sometimes people who are depressed can feel really on edge and sort of jumpy and restless, so they might come off as sort of agitated, or they might be experiencing psychomotor retardation, meaning that they're sort of slow and sluggish. It's taking longer to do things. They're actually moving more slowly than they usually do. So asking people about how their movements are is important. The next symptom is fatigue, which is very common with depression, just feeling like you don't have the energy, you are just so tired all the time. That is something to ask about. It's a very important part of depression. Feelings of worthlessness or guilt. Sometimes when people are depressed, they feel like they're not meeting the expectations of other people or their own expectations. They feel like they're not contributing as much, and they feel bad about that. Poor concentration or ability to make decisions is a part of major depression as well. So this kind of ties in with a lot of the other symptoms well. If you're feeling tired, if you're feeling sluggish, it may be harder for you to concentrate, focus on something, follow long conversations, read a book, and also to make decisions around things. If you're feeling so down and bad, it's not unusual to find that people are having a harder time making decisions. And then this last symptom is probably the most significant in terms of severity. If someone is having thoughts of death or suicidal ideation, we really need to know that. And thoughts of death, again, this is a little different than somebody who may be actively making a plan around suicide or has, taken steps. But you can phrase this in different ways. And so when I interview people around suicidal thoughts, I do ask them very directly, do you ever think about killing yourself? But then I also say, do you ever think about wishing like you could just go to sleep and not wake up? So more of a passive suicidal ideation. Because some people say, oh no, I would never take steps towards killing myself. There's so many reasons why I wouldn't do that, but I do wish that it could all be over. I don't feel like there's a point in going on. And if I were to go to sleep and not wake up, that sounds appealing to me. So that, too, counts as recurrent thoughts of death or suicidal ideation. All right. So these are the symptoms that are defined by the DSM as the criteria for meeting, these are the criteria for major depressive disorder. Is late life depression any different? Does depression present any differently among people who are older? Research has shown that there is a little bit of difference between people who are older and the general population. One thing is that we talked a little bit about feelings of sadness. Sometimes with older adults, they say that rather than sadness, maybe they're feeling like they have bad nerves or they're really irritable or anxious. And there may be a few different reasons why people endorse feelings of irritability or bad nerves. One is that it is kind of hard to put into words how you're feeling around your depression, and sometimes, especially when you look at different cultures, it's more okay to say you're nervous and you're you're feeling worried than to say that you're feeling sad. Part of that may be stigma. Think about, we're recording this webinar in the South. Is it more okay to say, oh, it's my bad nerves, or is it okay to say that I'm depressed? Depending on where you are in the country, kind of spiritual beliefs and cultural background, that can really impact the way that people talk about depression. But we do know that older adults actually have more somatic or physical complaints that come with their depression. And that's because there are often physical side effects that come with mood disorders. Older adults are more likely to talk about having aches and pains or problems with their GI or something going on in their body. And again, there may be different reasons why that happens. One, again, it might be a language thing. It might be a little easier to talk about physical complaints than mood complaints. It may be that they're actually experiencing more physical complaints. So different reasons behind that. And the last thing that we know is a little bit different among older adults is problems with cognition. You're more likely to see these slowed thoughts, difficulty concentrating, problems with memory with older people. And that tends to be because they've gone through so many more years of life than the general population, and their brains are a little bit more susceptible to the memory issues. But again, let me remind you that when you treat depression, people's memories tend to get better. So it's not uncommon for us who work with older people who are depressed to hear them say, I think I'm developing Alzheimer's, my memory is terrible. And then when you get them treatment for their depression, their memory is better. They're finding that they are able to concentrate better, and it probably wasn't Alzheimer's. So why do we care about knowing about someone's depression? Of course, depression impacts your quality of life, and we want people to be living as happily and healthily as possible. But the research also shows other impacts on the system, and in terms of health and social services, it's important to address depression. So we know that people who have depression have a lower compliance with medical treatment than people who are not depressed. And that makes sense too, right? Think about some of the symptoms that we talked about on the previous slides. If you're feeling kind of hopeless about the future, if you're feeling like you don't have the energy to do things, it's going to be harder for you to follow that diet plan or the exercise plan or to manage all your medications, So it's not surprising that compliance is lower for people with depression. What we find is that people with depression also have an increased use of medical services. On average, older people without depression go to the office about 2.9 times versus 5.3 times as seen in older adults with depression. And this could be for various reasons too. It may be that people aren't able to manage their health issues as well and they're needing more medical services, or maybe they're not feeling well and so they keep seeking more medical services. It's not totally clear what's happening, but we do know that it's almost double the amount of office services. Not surprisingly, more medical services is associated with increased healthcare costs. So people with depression have healthcare costs that are 50% higher than those who do not. And then again, depression is one of the most important risk factors for suicide. And older adults are overrepresented among suicide deaths in our country. So this is some 2004 data. When older adults made up 12% of the population, they made up 16% of suicide deaths, which is an important thing to know. This next slide, I almost always include these in my presentations because people can really see what the suicide rates are. And this is looking at suicide deaths in America, and it's looking at a 10-year period. And these different color lines are looking at the data by race and gender. So this purple line up top represents white males, the red line is black males, the green line is white females, and the blue is black females. Now look at what happens over the course of different age categories. If you're moving from left to right, there's sort of a similar pattern among black and white men over the years, but look at what happens around age 65. There's this incredible peak, especially noticeable among white males, but you also see something a little similar, a bit of a peak among black males. White women and black women, the shape of their line is a little smoother. It's less pronounced over different age periods, and they're a little closer to each other. But what do you think is happening with this purple line representing white males? Why is there such an incredible change at age 65? And this is, again, looking at national data. So this is looking at a huge sample over the course of 10 years. Well, there could be several different things at play here. Age 65 is right around the time that many people retire, and at least historically, men have worked more often outside of the home than women, although that's changing. And I do think that retirement is a really difficult transition for many people. Your identities, your sense of purpose, your income is all tied up in working, and then if you retire around age 65 or older, all of a sudden those things are different. And I also think our society thinks of retirement as the golden ages, like it's the time when you're going to be relaxing and walking on a beach, but that's not actually the case for many people, and it's a difficult transition. So something similar, I think, happens between black and white males around that age. Another thing to think about is coping. Coping with change, coping with loss tends to be pretty different between men and women. Research shows that women tend to talk more about how they're feeling when they have losses or bad things happen. Men tend to keep more of it in. It's less acceptable in our society for men to talk about what's going on with their feelings. And then the last thing that may be impacting creating this kind of the shape of these lines is that the methods by which men tend to try to kill themselves tend to be more violent than the ones that women try. So women actually make more attempts at suicide than men, but men choose things like guns or hanging, which tend to be more violent and more effective. Women tend to do things like take overdoses of medication. And so lots of different factors at play here, but really I think the take-home is that we need to pay attention to folks in this 65 and older age range. It's older people are overrepresented in suicides, meaning that there's something they're going through at this time that we need to be aware of. So again, depression is one of the conditions most commonly associated with suicide in older adults. And studies show that many older adults who die by suicide, up to 75%, have visited a physician within a month before their death. So to me, that's yet another reason why screening for depression is so very important among older adults. And again, if you look at this age 85 and older, which is a population that is growing, it's twice the national average. The suicide rate at age 85 and over is twice the national average. So I know that talking about suicide is a sensitive topic, and it can be a scary topic for professionals who may find themselves in a position where they have to talk to someone about suicidal thoughts. So I want to take a moment to go through a few myths and facts that are associated with suicide. So I know that you're listening to a recording, so you can't answer me, but look at the statement on the screen and tell me if you think this is true or false. Do you think this is a myth or a fact? That asking somebody about suicide may give someone the idea to kill themselves. Is that true or is that false? So just take a moment and think about what your answer would be. And I'm going to tell you that that statement was actually a myth. And the fact that corresponds with it is actually that talking with someone about suicide is not going to put the idea in their head. In fact, asking someone directly about their suicidal feelings will oftentimes lower their anxiety level and act as a deterrent to suicide. So this is based on research with people who have made a suicide attempt. And when you ask them, you know, did somebody put this idea in your head, they say no, no. And if someone asks me about whether I'm feeling suicidal, I'm actually glad that someone noticed and that somebody is willing to talk to me about it. Usually makes me feel less anxious. All right, so let's look at this next statement. Talking about suicide is usually a cry for help. Is this a myth or a fact? Is it true or false? Okay. That is also a myth. So talking about suicide is usually a cry for help, not actually true. What we know is that most people who kill themselves give definite warning signs of their suicidal intentions. 8 out of 10 usually give signs. And so that means that we really need to take all of people's statements, their threats, any attempts they might be having, we need to take it very seriously because you know, I think there is this idea out there that somebody who's talking about suicide might be being dramatic or they feel bad and they want people to pay attention to them. But most people, 8 out of 10, are actually, you know, contemplating real suicide, and we need to pay attention to that. And then here's my last myth or fact. Once a person is seriously considering suicide, there's nothing you can do. Is this true or is this false? So this, too, is a myth. All of my statements today were myths. So the fact is that most suicide crises are time limited and based on unclear thinking. So they're usually people are feeling suicidal when they're feeling really down and really bad. It doesn't necessarily last. It is oftentimes temporary. It's a time when people are feeling like they need a solution or an escape and they can't see other solutions. They are feeling desperate. So again, I think this drives home why it's so important to talk about suicidal thoughts because number one, you could be sort of a release valve for somebody who's thinking a lot about this, not feeling like they can express themselves. But then when someone notices, they tend to feel better. It's something that's very serious. If someone has any signs or symptoms of depression and suicidal thoughts, we want to make sure that we take them very seriously. And we know that I hope this is taking some of the fear out of talking about suicide because we know that people are sometimes thinking about suicide because they're feeling desperate, because they can't think of other solutions. And when you talk about it, that can get better. Okay, so this was my long preface for why we care about depression, you know, the impacts that it has on someone's overall health, and in the sort of worst case scenarios when someone's feeling so very bad that they might be moving towards suicide. So let's talk now about what are the first steps in doing something about identifying people who might be suffering from depression. So we're going to be talking about the PHQ-2 and the PHQ-9. And like I said before, the PHQ stands for Patient Health Questionnaire. The PHQ-2 is just 2 questions. And similarly, the PHQ-9 is 9 questions. And here's the trick. The PHQ-2 is actually the first 2 questions of the PHQ-9. So we're going to be using the PHQ-2 as sort of a trigger for the PHQ-9, so that if someone screens positive on the PHQ-2, you just ask the additional 7 questions that make up the PHQ-9. And they've tested this, and the research has shown that you can use the tools this way. So you might notice that the PHQ-2 and PHQ-9 look really similar to the diagnostic criteria that we talked through for major depressive disorder that came from the Diagnostic and Statisticals Manual. So we're looking at these 2 questions, and you're asking your client to think about the last 2 weeks of their life, the past 2 weeks of their life, and how often have they been bothered by any of the following problems. And we're going to list the problems below, and your client is going to rate them as something that has bothered them not at all, several days over the last 2 weeks, more than half the days over the last 2 weeks, or almost every day over the last 2 weeks. So in this case, this was given to someone. They can either answer it on their own by reading the questions and circling the answers, or you can read them out loud with them and help them go through it together. So here are those 2 core symptoms of depression that we talked about. So first question, how much have you been bothered by feeling little interest or pleasure in doing things? And in this case, this person circled more than half the days, so that's a 2. And then you ask, how often have you been bothered by feeling down, depressed, or hopeless? And in this case, the person circled several days. So at this point, you're done with the PHQ-2. It's just 2 questions, and you add up the score. So you notice that column 1, if they're not being bothered by these things at all, they get a score of 0, so you don't even need to tally that up. This person has a score of 3. And for the PHQ-2, if someone has a score of 3 or higher, they move on to the PHQ-9. So here is the first half of the PHQ-9. I couldn't fit all of the questions on the screen, so there's one half here, and then the next slide has the other half. And since we already asked the first 2 questions of the PHQ-9, you can skip straight to the question number 3. So again, same thing. Over the last 2 weeks, have you had trouble falling or staying asleep or sleeping too much? And this person rated that they are experiencing that problem more than half the days. And then you go on to the 4th question, have you been feeling tired or having little energy? And this person said that nearly every day they're having that problem. Question number 5 is poor appetite or overeating, and they said several days. And then question 6 is, have you been feeling bad about yourself or that you're a failure or have let yourself or your family down? And they said, they answered 2, which is more than half the days. And then, have you had trouble concentrating on things, such as reading the newspaper or watching television? Again, they said 2, which is more than half the days. And question 8 is, have you been moving or speaking so slowly that other people could have noticed? Or the opposite, being so fidgety and restless that you've been moving around a lot more than usual. So remember that criteria about psychomotor retardation or agitation? That's how this is phrased here. And this person said that they are experiencing that more than half the days. And then the 9th question is, have you had thoughts that you would be better off dead or of hurting yourself in some way? And this person said no. So they get a score of 0. Now, what you do at this point is you tally up each of the columns. So if you remember from the first few questions, they had 2 1s, and then they had 5 2s, and then they had 1 3, and that comes to a total of 15. And then there's sort of this bonus question in the PHQ-9. It's the 10th question that is looking at the severity of impairment that this person has felt. So you can ask this question, if you've checked off any of the problems, and if so, if they'd answered 0 to everything, you probably don't even need to ask this question, but if you've checked off any of the problems, how difficult have these problems made it for you to do your work, take care of things at home, or to get along with other people? And they answer whether their problems have made it difficult at all, not difficult at all, somewhat difficult, very difficult, or extremely difficult. And that kind of helps you get a sense of how much trouble are they having in their function. And the next page of the PHQ-9 is helping you to interpret the scores. So you've now got this score, and what does it mean? So the PHQ-9 scores of, and this should really read 0 to 4, means minimal depression. And that means that they might have some symptoms, but it's not, I wouldn't be too worried about them. They for the most part, have very few symptoms of depression. A score of 5 to 9 is indicative of some mild depression. So maybe someone's starting to feel a little bit down. It's not really getting in the way of their life probably, but they have some mild depression, and that might be worth talking about with them. Scores of 10 to 14 indicate moderate depression, 15 to 19 moderately severe depression, and 20 to 27 indicates severe depression. So the score range for the PHQ-9 is 0 through 27. And if someone's scoring high, that means that we have many symptoms of depression present, and we probably want to move them toward treatment faster than if someone has just a few symptoms. The cutoff point with using the PHQ-9 is a score of 10 or higher. So if someone is scoring moderate depression, moderately severe depression, or severe depression, we're going to count that as scoring positive for depression on the PHQ-9, and you're going to want to include that in part of their treatment plan. So the nice thing about the PHQ-9 is that it guides you through a conversation with someone about their depressive symptoms. It gives you a score, which helps you gauge how severe their symptoms are, and it's a pretty clear tool for explaining to someone how depression might be impacting them. And you can also use this as a communication tool with a family member or maybe primary care physician. It's a pretty straightforward way of educating someone around what you're looking for around depression, and then showing them that they are experiencing some of these symptoms. So you can also give the PHQ-9 different times over time, and that will help you know whether someone's depression is getting better, whether it's staying the same, or if it's getting worse. And that helps to inform your treatment planning, which can be the first step towards improving your client's quality of life. Another nice thing is that the patient health questionnaire is available online, and it's free and open to the public. It is found on here are two websites where you can find it. The PHQ Screeners website is where the developers of the tool have posted it, and there are other tools that they've developed there too. But the PHQ-2 and 9 are there and available. And also the SAMHSA, the Substance Abuse and Mental Health Services Association, the federal government, has posted the PHQ-9 and I think the PHQ-2. So you can always go online to find these tools. So at this point, I'm going to go on to some frequently asked questions. So, using the PHQ-9, you have a pretty natural way of opening up a non-judgmental conversation around depression, and that's nice. Because a lot of times people ask me, how do I talk to somebody about depression? Am I going to insult them by bringing this up? Is it going to be awkward? Are they going to feel angry towards me? I have done a lot of depression screenings, and rarely do people get angry at the questions, especially when they know that these questions are designed for a specific purpose, and they can just say no to them if they're not experiencing any of these symptoms. But I do find that people appreciate being asked about these things, because this is a pretty intuitive way of gauging somebody's well-being. Use the PHQ-2 as a way of opening up a non-judgmental conversation around depression. It's actually a great educational tool. And sometimes what I find is that I'm giving someone the screener and they're saying, no, I don't have any of these symptoms of depression, but this is making me think my sister does. This is reminding me of how down she is, and some of these symptoms are really a problem for her. So it can be a really great conversation opener. Other conversation openers, with someone who maybe screens positive for depression, you can say, have you felt this way before? And, that starts to help them reflect on how long has this been going on for me? Are there times when I was down before, maybe something was happening in my life? Another great conversation opener is, was there something or someone that helped you in the past? Another way of having someone reflect on what might be a strength of theirs that helped them in the past, or a resource like a person or someone they trust that was helpful when they felt depressed in the past. And then, as a professional, you may want to start moving them towards the idea of seeking some help. So you could say, would it be okay to speak to someone about what's going on? And most of the time people welcome that, especially if they're feeling really down. They may not really know what someone can do to help them, but again, just having conversation around how they're feeling is so important. So another frequently asked question is, what are the red flags that I should be looking for around depression? And that's a great question. Two red flags around depression are if someone is thinking of suicide, and that could be the passive suicidal ideation, or it could, the more emergency situation is if they are feeling like they will actually carry out a plan, that they've made attempts in the past. Things like that, that ups the severity, and that's a red flag to me about how bad someone's feeling and that they might need immediate intervention. And if you're doing the screening with them or talking with them and you're finding that their depressive symptoms are really severe, you don't really want to wait on that either. So two things that are, some helpful resources in an emergency. If someone is feeling suicidal, it is perfectly okay to call 911. That is considered an emergency. Another number you can call is the Georgia Crisis and Access Line, and that is a 24-hour hotline that's staffed by mental health professionals. And they will pick up and they'll talk with you about the situation. They'll get on the phone with the person. They'll help you find somewhere for them to be seen, or they can even send a team to the home. And the amount of time it takes for the team to get to the home can vary, but there is now coverage of mobile assessment teams throughout the entire state of Georgia. It's also perfectly appropriate to take someone to a hospital or emergency room if they're actively suicidal. And it is not an unreasonable thing to call a primary care physician and to get another health professional involved in the care for this person. Now, there's also non-emergency treatment for people with depression. So if you're screening someone and they're depressed, but they're not suicidal and their depression isn't so severe that it's impacting their ability to live safely, you still want them to get treatment, and here are some other options. You can think about involving a medical doctor, and that could be a primary care physician or a psychiatrist. I would kind of move towards whatever doctor this person has a good relationship with, trust and rapport, and also someone who can see them quickly and feels comfortable evaluating them further for their depression. That's kind of what you're looking for at this point. Sometimes people really don't want to see a doctor. Another great treatment option is to involve a therapist. And a talk therapist does not prescribe medication, but they are mental health professionals who will most certainly be familiar with depression. So that could be a psychologist, that could be a marriage and family therapist, it could be a licensed clinical social worker, a licensed professional counselor. Sometimes I find that people are, they don't want to talk to a doctor, they don't want to take any more medicine, they feel like they're on plenty of medicine already, but if you want them to talk about what they're feeling with someone who is a counselor, is a talk therapist, sometimes that's a little bit more acceptable to people. So think of these as some of your options if you are looking at helping someone seek treatment. So that brings us to the end of my presentation. I know that I covered a lot of different things today, ran through a lot of facts around depression, and I really do welcome questions from the public. Please look to our website. Feel free to contact me. This is my direct contact information at the Fuqua Center. And I greatly appreciate you joining for this training on depression and depression screening. And I even more appreciate the work that's being done by the Georgia Division of Aging Services. You work with some of the most vulnerable members of our society, and you provide services that are really important to helping someone to live their best for as long as possible. So I hope the information we covered today will help you in that work, and please do reach out to me with questions or comments.
Okay, Jocelyn, thank you. Do you have anything else?
That's it.
Alrighty. Again, I wanted to say thank you for all the information that you showed us here, and I'm sure it's going to be very valuable to their future screenings that they're going to be doing. And I just wanted to also take a moment and say that I enjoyed hosting this session, and that I wanted to remind our listeners to complete the post-test that's going to accompany this webinar's link. You'll find it right below the link that you clicked on to get to this webinar here. And that again, I'd like to thank all participants. And if there's nothing else that you have, I'll be stopping this recording here.
All right. Well, thank you so much.
Alrighty, thank you again.